Thank you guys for joining Pre-Health Shadowing. We are an international student-led, women-led, minority-led nonprofit for medical advancement. We do have closed captions available to accommodate students of all abilities and needs. And if you have any ideas on how we can be more accessible, feel free to email us at info@prehealthshadowing.com. Make sure to save us as a contact to keep us out of your spam and join our email list to never miss a session. And if you want to stay in the loop, make sure to sign up for our email list and follow us on our social media. Our social media handles are the same for Instagram and TikTok at Pre-Health Shadowing. And we do host students from all over the world, so type in the chat where you're calling from today. I'm calling from Texas. If you're interested in being part of the Pre-Health Shadowing team, we do have opportunities for student volunteers and team members. You can find more information about that on our website or just take a screenshot of the links shown on the screen. And our positions are completely 100% remote. We also have opportunities to join our leadership team, so you can apply for those on our website. Here are just a couple of the roles we have available, but we have a full section, a full list on our website. And if you are a high school student, you can join our high school training program, HTP, which is offering leadership and healthcare education for all pre-college learners. There is also an application for that on our website. And if you can, please donate to help our program stay free and accessible to all. We do run solely off of the time and donation of our volunteers. If you have any questions at all, please type them in the chat and our co-host will ask them during the Q&A session. And please make sure that you are taking good notes, as we will have a post-shadowing assessment, which will be available to take to earn a digital certificate verifying your hours on our professionals course page at Pre-Health Shadowing. And please make sure to turn your cameras on if possible to help make this as close to a true shadowing experience as possible. We know it's not always possible to turn your cameras on, but a little face-to-face can go a long way. And now on to our professional, Dr. Jones, to take away the screen.
Great. Thank you. Good evening, good afternoon, good morning, I guess, depending on where you are. Thank you for joining me this evening. I'm so excited to be with you. My name's Lee Jones. I'm in Washington, D.C. I'm the Dean for the Medical School at Georgetown University School of Medicine. I've been here for about 2.5 years now. So I'm going to share my screen now, and we will just launch into it. I'm assuming everyone can see that, I hope. Good.
Perfect, yes.
Perfect. So that's me, obviously. This is me in front of the medical school building. Georgetown Medical School actually started in 1851. The university's been around since 1789, and the building behind me has been, I believe, was built in the early 1900s. So what I'm planning on covering this evening, this is just an outline. My background and training, telling you a little bit about who I am. I'm a psychiatrist and what I've been doing in psychiatry. The other part of my career has been School of Medicine leadership. I'll talk some about that, talk some about national service that I've done. Then I want to talk a little bit, for hopefully your benefit, of just a couple of slides on School of Medicine admissions for any of you that are interested in hearing what School of Medicine, what we're looking for when we're looking for future doctors. And I'm going to finish with a few slides on self-care, because it's really important, no matter what it is your future dreams are, to maintain self-care and take care of yourself. And then there'll be questions and answers. So my training is, I grew up in northern Maine in upstate New York, near Syracuse, a town called Rome. I actually went to Dartmouth College in New Hampshire and got a Bachelor of Arts in psychology. And did all the pre-med courses. And from there, I went to Columbia University in New York to get my MD, thinking that I was going to be a primary care pediatrician, having been a camp counselor for many years, and then realized that I'm not sure I could handle really ill kids. So then thought I would go into surgery and got really interested in pediatric surgery. Don't ask me why I could handle cutting on kids and not handle sick kids, but that's how I started. But I wasn't completely sure. So from there, you go into residencies, and you can either do a straight residency, which is 5 years of general surgery, 4 years of psychiatry. and the internship is included in that, or you can do a separate internship to help you decide what you're going to go into, and that's what I did. So I left New York City to go to Seattle, where I did an internship in a hospital called Virginia Mason. And I did what's called a rotating or flexible internship. So I did medicine, surgery, peds, and OBGYN. And I did it to help me decide what I wanted to go into. And I settled on psychiatry. And the way I was introduced to psychiatry is I would be making rounds on my patients for medicine, or surgery, and there'd be someone sitting there talking to the patients. And I love stories. And so I thought, who is that? And I found out it was someone called the consultation liaison psychiatrist. And I'll get to that again in a moment. From there, I actually went to UCLA for my residency, UCLA Neuropsychiatric Institute, where I did my remaining 3 years specializing in psychiatry. And at the end of your residency, you can do something called a chief residency, where you get to sort of be a leader in the residency. And so I did a chief residency where I ran one of the inpatient psychiatry units and got a real great opportunity to teach third-year medical students, fourth-year medical students, and second-year psychiatry residents, and sort of got bitten by the bug for medical education then. When you finish residency, you can actually go out and practice. You can take specialty boards, and there are national exams that give you a specialty certification in psychiatry, which I did. But you can go on after that, instead of going straight to practicing, and do something called a fellowship. So pre-med, which is college, medical school, and then you do a residency, and then you can go out and practice, or you can go on and specialize within that field. So for example, if you do orthopedic surgery for residency, you can go on and do a hand surgery specialty. Or if you go into pediatrics for 3 years, you can go on and do pediatric hematology oncology and take care of children who have cancer. I actually chose first to go into research looking at oncology. So I did a clinical and research fellowship at Memorial Sloan Kettering Cancer Center in New York, specializing in my particular interest was lymphomas and leukemias, so diseases of the immune function, body functions. And from there, I got sort of so wowed by that, I went into a pure research fellowship at UCSD, University of California in San Diego, for a year. And after that, I finally was ready to get out and practice. But I had really specialized in consultation liaison psychiatry. So let me say a little bit about what that is. So you probably have an idea of psychiatry in general. The movies were portrayed as therapists in an outpatient setting doing therapy or prescribing medications. And sometimes we're portrayed in a psychiatric hospital where we take care of patients who are hospitalized for psychiatric illnesses. Well, consultation liaison is the specialty in psychiatry that takes care of people that have medical illnesses. We call them comorbid psychiatric and general medical conditions, typically in hospital, where there's also outpatient consultation liaison. This is from the American Psychiatric Association. The role of the consultation liaison psychiatrist is that of linking between psychiatry and other medical fields. So we see patients that are being treated for other medical things that may have psychiatric issues or symptoms. So let me give you a few examples of what that is. So what are the kinds of things that we see as a consultation liaison psychiatrist? A very common one, and probably one of the first one that comes to mind, is medical illnesses cause significant stress, psychological issues, and indeed existential issues around life and death. So we often are called in my work at Memorial Sloan Kettering Cancer Center, where it's a full hospital of cancer and HIV/AIDS. It's really stressful to be diagnosed with a life-threatening illness. So often psychiatrists are called to help people manage that. It can be very stressful to manage things that seem less life-threatening, like diabetes, but it changes people's lives. So we are there to assist people as they transition and become accustomed to and maximize their treatment for medical illnesses. But there are also psychiatric illnesses that lead to a medical admission. So we are in the hospital, and someone may be followed by a psychiatrist as an outpatient, or may not be followed at all, but they enter the emergency room and or the hospital, or perhaps an outpatient clinic, and we see them because there's a connection between psychiatric illness and their medical illness. Here are just three quick examples. One is substance use. People come in intoxicated. They can come in psychotic and paranoid, depending on the substance they use. And so we get called because we can help manage their behavior and keeping them calm. We can also help differentiate between, is it substance use that's causing this? Is it a psychiatric diagnosis that's causing this? Or is there a medical illness that's causing this? I'll get to that last one in a moment again. Oftentimes we're called to the emergency room or to see people in the hospital who have made a suicide attempt to assess how serious the attempt is and whether they need to go on to a psychiatric hospitalization, or in the case of a very serious suicide attempt where they've taken an overdose that necessitates them to be admitted to the intensive care unit, we follow it along with them and make sure that their psychiatric needs are taken care of as their medical needs are addressed, and then help transfer them to the appropriate psychiatric treatment once they are medically stable. The other thing that we will sometimes see is psychotic disorders, where people have hear hallucinations, hear or see hallucinations, or have delusions where they are disconnected with reality. And we can see people who will do things that are not in their best interest. They may eat things that are not appropriate to be eaten, or they may walk into traffic because they're listening to the voices in their head. So those are just three quick examples. The other kinds of patients we see as CL psychiatrists are medical illnesses that present as psychiatric illnesses. So people present with unusual behavior, depression, anxiety, hallucinations. And probably the largest one we see is something called delirium. And you've probably heard about people being delirious. It's talked about in the movies sometimes. And what delirium is, it's really something is gone awry in your body, a chemical imbalance that may be related to your liver or your kidneys, or your heart isn't functioning as well. And so what that does is it affects your brain in such a way that you have what we call an altered mental status. You may hallucinate, you may become very drowsy, you become very agitated. And delirium is very important to treat. So one of the things that we do as consultation liaison psychiatrists is we help the treatment team differentiate between delirium and psychiatric illness, because the treatments are very different. And the reason it becomes very important is because since delirium is the presentation for a medical illness, that medical illness could be life-threatening. So someone may present with a delirium because their brain is not getting enough oxygen related to perhaps a pneumonia. And if you treat it as a psychiatric illness and let the pneumonia go untreated, that could lead to very serious illness and death. Other examples of that are people that have seizures. You may know people that have seizures. There's several kinds of seizures that people can have. There's lobes of your brain. There's the temporal lobes, which run sort of by your ears. And it turns out that seizures there don't cause additional muscle tension and variety things. They cause change in your perception and behavior. So they're called temporal lobe seizures or partial complex seizures. And we can help distinguish that. And the last is cancer. There are a variety of cancers, most notably things that are pancreatic cancer and what's called a small cell lung cancer, that when you see people that have new onset depression, for some reason, and we're not completely sure why, some of the cancers, the two that I just mentioned, and several others, can present with a delirium, or they can present with a depression. So we get involved with that. The fourth kind of patient that CL psychiatrist sees are psychiatric illnesses that present as medical illnesses. So for the example of that, a couple of examples is anxiety. When people get anxious, they start hyperventilating, they get short of breath, they get chest pain, and they can have symptoms that very much mimic having a cardiac arrest, a heart attack, or an arrhythmia. Somatiform disorder is a disorder where a variety of disorders where people's psychiatric issues manifest as bodily functions. And so it becomes very important to recognize those as, I mean, we always rule out if someone presents with something that looks like a cardiac arrest or a heart attack happening, we always address that first. And as we're working that up and making sure that's not what's going on, the psychiatrist will come in and begin to assess for anxiety and treat that. Just three more kinds of things that we see. Often treatments for medical illnesses can cause psychiatric symptoms. So for example, there's diseases called connective tissues diseases like lupus can cause a variety of symptoms. In lupus, the actual illness can cause psychiatric symptoms, but the treatment for autoimmune diseases tend to be steroids amongst a variety of other meds. And steroids, and depending on the person, can cause complete mimics of psychiatric illnesses. So in some people, it can cause depression. In other people, it can cause a state that looks just like a manic state in bipolar disorder. So many times, and for example, if someone has to come in for recurrent treatment for an autoimmune disease, or sometimes steroids are used to manage the side effects of medications used in cancer, we will often, if someone has a history of responding that way to steroids, the consultation liaison psychiatrist will see that person every time they're admitted, and we will pre-medicate them to adjust for the steroid treatments they're going to get. The last two I just wanted to cover quickly is psychiatric treatment that causes medical symptoms or illness. So our medications that we use in psychiatric diseases can also cause medical symptoms. So a very classic one is lithium. It's a medication we use to treat bipolar disorder, manic depressive disorder, and it can, in certain people with long-term use, cause both kidney disease and thyroid disease. So we as consultation liaison psychiatrists, as well as general psychiatrists, look at and follow the kidney disease and thyroid disease medications. And there's a variety of other medications. Many of the antipsychotic medications, the medications we use to treat psychosis, can cause cardiac or heart symptoms. So we have to be wary of that. And the last is psychiatric illnesses actually increases the risk of medical illness. Perhaps the most well-delineated one is that depression puts you at risk for worse cardiovascular disease. And we're still working on what that connection is, but we do know that there's a connection. So what happened is, as I was moving into my medical education roles, and I became the dean of students I've been the dean of students at 4 institutions, medical schools now. My work in consultation liaison psychiatry, which takes follow-up and a lot of ongoing care, became more difficult because I was so busy with medical education in the dean's office. And part of what we do as consultation liaison psychiatrists, if there's not a freestanding psychiatric emergency room, CL psychiatrists will also cover the emergency room. And so in most of my jobs as a CL psychiatrist, we covered the emergency room. Emergency room psychiatry is the clinical application of psychiatry in emergency settings. Suicide attempts, substance use, depression, serious suicide ideation, violence, and other rapid changes in behavior. And so as I moved into more of leadership and medical education, I moved more into the emergency room because I could do a 4-hour shift and be done. Whereas if I was working with liver transplant patients or bone marrow transplant patients or patients that had seizures, it was very difficult to come and go based on what I needed to do elsewhere in my job. So what are the psychiatric positions I've held? The actual single asterisk means that I had a leadership position there. So my very first position out of my second fellowship, the one at UC San Diego, is I ran a locked inpatient psychiatric unit at Tulane Medical School in New Orleans. From there, I went completely back into consultation liaison, where I ran for the next 4 jobs the consultation liaison service, first at UCLA, Sepulveda VA Medical Center, then at Kaiser in Los Angeles, their main hospital there on Sunset. Then we moved to Minnesota, Health System Minnesota, where I ran the consult service, and ultimately moved to San Francisco and ran it at UCSF. From there, I moved into doing medical education, but UC Davis is on there because I was able to, for a brief time, do both consultation liaison and do medical education and leadership roles. But that's where I really shifted into doing mostly emergency department because I was able to do shifts there. So what do I mean by medical education? Medical education is a continuum of education that starts typically from medical school. For some of you people, it may start in post-bac or master's things. So medical school followed by residency training and or fellowship training into practicing. And so we have the education continues all. Obviously, there's a lot of learning that goes on in medical school. It continues in residency when you specialized in urology or psychiatry or OBGYN. It can continue on. Your education continues when you, as I told you earlier, when you go on to a fellowship where you specialize from OBGYN, you may go into for high risk fertility training, or urology, you may specialize in cancer or oncology. But then each of us, as you become a physician and are finished with official training, to maintain your licensure in all 50 states, as well as to maintain your board certification. I'm board certified in psychiatry and neurology, American Board of Psychiatry and Neurology. We must do so many hours, 25 hours of continuing medical education every year to show that we are continuing to learn. And most of our specialties have additional requirements for us to complete to maintain our specialty. So that medical education is a lifelong thing. And I've had the great pleasure of being involved with teaching and organizing across the entire spectrum. So the art of medical education, which to me is the most exciting part of this, is it's being able to design what the doctors in the next 50 years will need. So thinking about what are the needs now and will be the needs of our communities in the near future, and how do we design an education system and programs that both give people what they need to know now, as well as enable them to learn things as they move forward there. So it's really about how do we train in people to cope with the health systems and community needs as life continues. I can tell you that when I look back on my medical education, there were actually times when I started medical school, Hodgkin's lymphoma, which is one of the immune system cancers, was quite fatal in children. It's now essentially curable. So there's been many, many, many advances. And so part of what we need to do in medical education is teach people how do you become a lifelong learner and unlearn things that you learned that now no longer work and may indeed be proven to be wrong, which happens in medicine. So what do I do now? And what does medical education look like from a leadership perspective? So every medical school has the dean of a medical school. That's what I do now. And then there's several other deans, either called senior associate deans or vice deans or associate deans, that cover the needed areas in medical school. The asterisks are positions I've held across my medical education. So there's admissions and financial aid. I was actually an admissions dean and for a while. There's curriculum deans, and those are the people that design the curriculum and maintain it and update it. There's student affairs. That's the office. And the reason there's 3 asterisks there is because I had 4 student affairs jobs at 4 different institutions, medical schools, and that's who supports students' needs, their learning needs, their mental health needs, and a variety of other needs. There, diversity, equity, and inclusion is another dean that's typically present, although that has changed in some states in the United States here with the Supreme Court decision. International programs, most medical schools have the ability, programmatic ability for students to do rotations and provide and learn about medical care around the world. Graduate medical education is what we call residency. So we call medical school undergraduate medical education. We call residency and fellowship graduate medical education, and we call practicing physicians continuing medical education. Typically, there's a dean of operations. Then we have deans of assessment and educational scholarship. And assessment is how do we determine that someone's learning what they need to learn, and how do we help them if they're not. And then there's knowledge management team that here at Georgetown happens to be the senior associate dean that manages our library, and that's and the staff there that is very integrated into the curriculum and research endeavors at Georgetown. So I've had multiple School of Medicine dean positions. These are my 5 institutions. It began at University of Texas, San Antonio, where I was the Dean of Student Affairs. From there, I went to the University of Arizona in Tucson, where I was the Dean of both Student Affairs and Admissions. Then I went back to pure Student Affairs at UC Davis, and then at UCSF, University of California, Davis, University of California, San Francisco. And then I came to Georgetown to be the Dean here at the medical school. Just quickly going over a couple things that medical education is about. We look at, on the right-hand side, the core values of what's important in the practice of medicine. And this guides us along, starting with who teaches, who gets hired, what are the priorities. It extends to what are we looking for in applicants, and I'll get to that in a moment, some of what medical schools look for in applicants. But integrity, cura personalis is something here at Georgetown. We're a Jesuit institution. Cura personalis means care of the whole person. And really, we also think about care of the entire community. We're founded on core values of respect and dignity, professionalism, equity, inclusion, and diversity, health and healthcare for all, and lifelong learning. Again, the lifelong learning is very important because medications that we were using that was the medication to use as little as 5 years ago, now are no longer being used because of side effects. So we have to be really lifelong learners. On the left-hand side, we use guiding principles, the core values I just mentioned. We really focus on excellence, collaboration. Medicine is a team sport, and it's not just other physicians, it's nurses, physical therapists. It's also dietary, the food services, and it's also people that help us do our best in the hospital. So janitorial and cleaning services become of paramount importance, not just in the general hospital because it needs to be a clean place, but in the OR, operating room between cases, the room needs to be cleaned and sterilized. So it's collaboration across a variety of people. We actually look at the integration of biomedical science, behavioral science, educational science, how do adults best learn, population health, and health system science. We incorporate humanities. We here at Georgetown have a humanities grant looking at how we incorporate humanities in medicine. And more, we're looking at engineering with devices and moving forward with advancement of how we take care of patients. We also focus that our education practice is grounded in the context of community needs. So we are partnering with communities more and more, as opposed to going into communities and doing what we think they need. We partner with them to find out what it is they need and how do we best help them improve their health. As I said, it's continual active acquisition and application of knowledge. So we have to make sure people have outstanding clinical skills. That begins here at Georgetown. At most schools, it begins literally the first or second week of medical school, where we focus on teaching people introduce skills and moving on up to you learn about every part of the body multiple times, from the micro level to the macro level to gross anatomy to x-rays, medications, a variety of things. We use a competency-based education system where we actually look to make sure that you're competent, not just that you can cite back what we've taught you, but that you understand how to actually take that information and knowledge and apply it as you think about things. And then we also do assessment to make sure people are doing that. More and more medical schools are getting involved in advocacy because physicians, we have responsibilities to care for communities and advocate for what's best for communities. And we also focus on having a shared vision in medicine of what's important in medicine. What are some of the challenges we've had recently? Just to give you an idea about what my life is like, what kinds of things do I work on? Health and healthcare equity writ large. I can tell you here in Washington, D.C., where we're located, the capital of what is perhaps the wealthiest nation in the history of the planet, the difference between the life expectancy in our wealthiest, we call them wards here, and the wards that are underrepresented or disadvantaged, the African American ward, the difference, depending on the study, is either 16 years or 26 years difference just based on the zip code review. That's clearly related to a variety of things. There's the social determinants of health. One of the examples I can give you is that in the ward that has the best life expectancy, they have roughly just under 70,000 people living there. There's, depending on how you look at it, 18 to 22 full service grocery stores. If you look at Ward 7 and 8, which has about 170,000 people living in it, they just went from 3 to 4 full service grocery stores. So even just access to decent food makes a difference. We're concerned about the cost of healthcare. It's spiraling out of control. As a nation, we have one of the highest healthcare costs, but we are in many ways, including maternal fetal health, fetal death rates, we are in the teens or worse. There are multiple countries in the world that do a better job, much more efficiently, with much lower cost than we do. So the cost of healthcare combined with the quality of healthcare is on our mind. Equity, inclusion, and diversity, I've already mentioned some of that, health and healthcare equity there. As well as, when we look at the history of medicine, we have not always done our best at being fair and equitable in how we treat patients, and also how we obtain medical knowledge and who we experiment on. There's been multiple medical education crises, the financial challenges, the political turmoil. Here in DC, we had to deal with the January 6th issues that were going on. We've also had to deal with learning, the distance, isolation, patient care, doing more telemedicine, professional development, professional identity formation. The average age here at Georgetown of a entry medical student is 24, but the age range was 20 to 38. So we have people that technically, legally can't drink alcohol yet, on up to people that were literally, second in command of nuclear submarines before they went back to do things. So how do you actually bring that diverse cohort forward in professional identity formation? Wellness, focusing on that, looking at the exploding knowledge. I've already mentioned that there's so much to know, and there's more and more is happening. There's changing assessments. We're learning how to assess people better. The cost of the MD, the average debt for a medical degree for all comers in the United States is just under $200,000 for medical school. That's a huge debt for people to take on. We also have to think about how do we teach people to become critical thinkers, exploration of increasingly complex issues, challenging conversations, justice, and mistrust of science and medicine, which has been there for a while, but COVID-19 has clearly made that worse. So we're thinking about how do we address that. We've done a variety of things. I'm not going to go into detail. This is just some of the things that those of us in leadership worked on with the COVID response. We had to be concerned about safety, about protective equipment and resources, community health care, and we had to think about clinical training. As we were learning about things literally day to day, we had to adjust our education and training. So just quickly, my national work, the Association of American Medical Colleges is a group that actually does a lot of things with medicine in the United States education. They actually own the MCAT, the Medical College Admissions Test, the AMCAS, which is the process to get into medical school, as well as IRAS, which is the part of the process to go from medical school to residency. My positions there, I've done holistic review in admissions, where we trained admissions people how to be holistic and take a much more broad look instead of just looking at MCAT scores and GPA, looking at other things that they needed to look at. Let me grab some water here. I've also had the great pleasure of serving as the Group on Student Affairs National Committee officers. There's 157 medical schools in the United States now, and all of us have admissions, student affairs, diversity affairs, financial aid, and student records. So this is a group nationally that oversees and helps organize the people that do that. I've actually been able to had the honor of being a leader of that. The MSPE, which stands for Medical Student Performance Evaluation, that's a summary of a medical student's work. I had the pleasure of chairing the task force for that. And I currently have the great pleasure and honor of serving on the board of directors for the AAMC. And this year I'm the chair of the board of directors. And there's also a wonderful organization where the deans of all 157 medical schools get together at least monthly on Zoom and a couple of times, like 2 to 3 times a year in person, to talk about national issues around medical education. I also have had the great pleasure of working on the Liaison Committee for Medical Education. That is the organization that accredits medical schools in the United States. So we get to review medical schools of our colleagues and make accreditation decisions, advice so that they can make the decision. There's several other accreditation things that we work on. I've had the pleasure of doing a lot of pre-med advising and working on pipeline programs. So let me quickly shift gears, talk a little bit about what medical school admissions looks at, maximizing healthcare and maximizing the health of all. That's our goal. That's what medical education is about. What is it that goes into a medical school application? There's the AMCAS, American Medical School Medical College Admissions Service. That's where you submit your essays and all your information. There's the MCAT, Medical College Admission Test, which pretty much every medical school requires. We look at your GPA, both your overall GPA as well as your science GPA, because that's an indicator of how well you'll be able to handle medical school. We look at letters of recommendation, typically 2 to 5 or so. We look at what academic degree. You have to have had an academic degree to start medical school. Most people apply before they're getting. I applied as a senior in college, so part of my acceptance was conditional that I finished my degree and got it. And then we ask people to submit secondary application essays that help us further figure out who you are, get to know you a bit, and whether you're a fit for our medical school. All medical schools look for 15 core competencies, and I know this looks daunting, but we look for I'm not going to go over that list. It covers a variety of things of what we think it takes to become a good doctor. And the next slide distills it down into what are the questions we are really asking with those core. One is, can you master the academic rigor requirements of being in medical school? GPA, MCAT, what your major has been, your science courses. Have you been involved with scholarly activities, research, service to national organizations? That helps us look and see, do you have bandwidth to do a variety of things? What is your range of interests? Do you really understand what you're getting into? That's why we ask for people to shadow and do a variety of things, just to make sure that you don't get into medical school and you don't realize what it actually entails. Have you been involved with service activities? And we like to look at, not that you've done an hour here, an hour there, an hour there, but we like to see sustainability, where you've done something for several months, perhaps even a couple of years. And it can take a variety of things. Do you have leadership experience? And we don't mean necessarily just being officers, but have you been shown initiative? Physicians are often, if not always, leaders in their community and look to, and so we want to make sure that people have leadership interests. What talents and skills do you bring to the school, to their mission, and to medicine? And who are you as a person? Is the school and medicine a right fit for you? With 157 medical schools, one school may be very, very strong in research, another school may be very, very strong in primary care. So it becomes important for us to figure that out. I'm going to shift gears now and talk a little bit about just some advice moving forward as human beings. I would be remiss as a psychiatrist not to address health and well-being, because all of you are on paths and journeys that will have ups and downs, that have stressors. Things are competitive. And guess what? When you get into medical school, there's a lot of things to deal with. You will see people in situations that you can't even imagine, and you will see people die of all ages. You will see people who have very hopeless living situations. And so it becomes very important. And that's not just medicine. You see that in law, you see that in teaching, you see that in walking down the street. So these are just general ways to approach things. So one of the things is, recognizing that challenges are not bad things. Challenges for most of us bring excitement, they bring fears, they're unknown. That's why it's a challenge. But I like this quote: life's challenges are not supposed to worry you. They're supposed to help you discover who you are and see how far you can go. They really are ways for us to learn and grow. And so many times you think about something being too challenging. I believe that if your life didn't have challenges, not at all times, it's nice to have a vacation where there's not challenges, but you might be actually bored. So recognizing that challenges are things that can be really wonderful. Growth is something that's very important. My husband and I have 3 dogs. We have 2 St. Bernards and a Mastiff. This is our male St. Bernard. His name is Angus, and the little Peanut at his back there is a Mastiff, and his name is Toby. He weighed 11 pounds when we got him. And this is my favorite example of growth. This is the same 2 dogs a year later. Toby weighed 200 pounds. He was gaining more than a pound a day. He is the gentlest, sweetest dog. He actually runs away from loud noises because he's the big thing. And that's our male St. Bernard Angus. Our female, Angus's litter mate. They're rescues. Emma is actually our warrior princess. She's the one that protects and guards the house there. But this is just my favorite example of growth. So when you go into medicine, there's growth in knowledge, and it continues lifelong. There's professional growth. You have multiple opportunities. I've given you some of my life experiences where I, was a clinician. I'm an educator. I'm a leader. I get to make policy and a variety of things. And there's also personal growth. You learn how to handle things. For some reason, you don't ever want to fly with me. I have had multiple emergencies on airplanes where maybe you've been on a flight where they say, is there a doctor there? For some reason, I'm always on those flights, and I'm frequently the only doctor. But the personal growth is around, I know how to do that. I can step up to do that. Emergencies don't scare me, as well as I get to know people. It's such a pleasure getting to know patients and being a part of their life. Personal growth for me, particularly for me, if it's in the transition from them living to them dying, and helping them with that transition, helping their families with that transition. So that's one of the wonderful things about medicine. There's several things that I have in this talk. I've been using them for so long, I cannot find the credit. This is one of them, so there's a big credit to this. But the balance of the wheel of life, these are things that are very important to maintain in your life. Obviously, finance, career, family and friends, health, spirituality, personal growth, relationship, fun, and recreation. And as you all know, those of you that are in school or working, the size of these get larger or smaller. Finance may be an issue if you're, buying a house, personal growth. And the thing I want to leave you with is you never want to have your life so unbalanced that 1 or 2 or 3 or 4 of these completely disappear from what's going on with you. You need to figure out, and it's a struggle at times. As a surgical intern, when I was on general surgery, I was on call every other night, which meant that I got 6 hours of sleep every other night because I was up for the nights between. It becomes hard to maintain relationships then, but in some ways it becomes even more important to figure out how to do that. I want to leave you with some things about the kinds of supports that are most important and helpful for you as you move forward. And there's just several kinds. Again, I've been using this for so long. I don't know where I got this from. I Googled it multiple times. I can't hear it. But you need individuals or creatures. I'm obviously a believer. We have 3 dogs and 2 cats that provide intimacy with you. They provide closeness. They provide warmth. They frequently are the people or creatures you cuddle with, or that put their arm around you or rub your arm when you need it. They give you acceptance, and they accept you for who you are, and they're accessible. You need to make sure these people are in, and you have people in your life that stay in your life. You need to have people in your life that you share things with. They're in the same boat. I suspect those of you that are pre-med have multiple things that you could just say, organic chemistry. And I know when I say that to any of you that are pre-med, I see several of you smiling. We all know what that's about. We're all in the same boat. It's this crazy thing that you have to get past. You need people that value your self-worth and respect your competence. Going into medicine, going into college, going into many things in life that are challenging. It's a brand new opportunity to feel like an idiot. And you need to make sure that there are areas in your life that you're comfortable for, and recognizing that you didn't lose the areas you were competent in before. It might have been a sport, it might have been singing in your church choir, it might have been babysitting, it might have been you were an Olympic athlete. But you need to make sure that there are people in your life that help you maintain your ability to see your self-worth. You need to have people that provide you assistance. They provide tangible services and make resources available. That often is student affairs. That was my job in medical school. There are student services in colleges and high school. You have advisors. In jobs, it's human resources. Where do I go to get parking? You need people that provide guidance, provide advice and methods to solve problems. These often are advisors and mentors. They listen. They often reflect back to what's going on and help you solve problems and think about how to approach things. And lastly, you need to have people in your life that are nurturing you. These may be the people that are also the people that provide intimacy, but these are the people that take responsibility for your well-being. For me, it's when I come back to my office after a crazy clinical day or crazy meetings, and someone has left the world's best chocolate bar on my desk for me. That's what, that means I've been seen and heard, and someone's taking care of me. And actually, what's interesting is part of the way I nurture. When I was a resident, the cafeteria checkout people always knew when I was having a stressful day, because for lunch I would have a piece of pie with 3 scoops of ice cream. That was the way I got through my stress. They're like, bad day, and several times they would just comp it. They're just like, you deserve this. You don't have to pay for it. Wonderful. So what are practical approaches? I don't even have this in one more slide, I think, is learn and accept your limitations. And there are probably several of you when I said that, wait a minute, I don't have limitations. We all have limitations. We don't have, we have gas tanks that need to be refilled. We need to take time off. There are things that I'm still not good at. In medicine, I think I'm a pretty good physician. I cannot remember how the kidney works for the life of me. So every time I have someone that has a kidney thing, I have to go and reread it. I recognize that that's a limitation, but I know what to do to get around it. You don't have to be everything for everyone. And as a matter of fact, you can't. Many of us that end up in health fields are the people that for our entire lives, people have come to with their problems. And I suspect many of you are the people that your family members, your friends come to, because that's who gravitates to healthcare fields, kinds of things. But you can't be everything to everyone, and you have to take care of yourself. Always remember, you're not alone. There is always help, even if it's an anonymous phone call with a helpline. But typically, there are people around you, be it at school, be it at your church, be it in your volunteer services. You need to remember you're not alone. And the last thing is to ask for help. One of the hardest things to do is to ask for help. I started medical school. As I said, I was a psychology major as an undergrad, but I sort of wrote my own major between psychology, anthropology, philosophy, and education. And so I made the mistake of when I got to medical school, I studied with several other people that were social science and humanities majors. And we had a biochem exam, and we decided they can't possibly ask us all those silly little 6-carbon things, the Krebs cycle. Social science and humanities, they give you facts and you have to show how you manipulated them. I remember sitting in that auditorium making eye contact with my 4 other study partners thinking, we are so in trouble, because that's exactly what the exam was. I got a 27 on that exam. So I failed the first exam of medical school hugely. And what I did is I didn't ask for help. I just did more of what I've been doing very efficiently. So I failed the second exam. And then I didn't ask for help. I got called in by the biochem department and said, you need help. the ultimate thing is, luckily they graded on an improvement, so I actually got an A in the course. But there's a couple of messages there. One is I learned how to ask for help, and the other thing is you can stumble, and I'm still the dean of a medical school. So I failed the first two courses, and what I did, not by my own, but what I learned to do was to get help. So it's really important to get help when you're struggling, or to get help. I don't know how to do this. What's the best way for me to do something? Actually, three more slides. So what are the final things? Helpful strategies, establish priorities. They need to be personal, meaningful, and creative. It can be very helpful to write them down. Where is it you want to go, and to look back on those. Nurture friendships. I do not spend most of my waking hours with my husband or my dogs. I spend it with colleagues at the hospital and at the School of Medicine, and my colleagues in the dean's office and faculty. You need to nurture friendships with the people you're spending time with. Be proud of accomplishments. All too easily, when we go to sleep at night, we tend to focus on perhaps the 3 seconds where you felt like you were an absolute klutz or made a huge mistake, forgetting the other 4 hours of the day where you were really on the top of your game and did things well. So you make sure you take credit in the things you do well. It takes effort to focus on those things. Build leisure into your life. What I used to do is I'd fill up my calendar, and if there was a hole there, I'd be like, oh, maybe I can go to a movie there. That's not the way you do it. Now what I do is I actually put leisure on my calendar first. It may have to move, but I have a rule that it doesn't get deleted, it moves. So you need to make sure there's leisure in your life. And lastly, and this can be difficult with all that's going on in the world, is live in a spirit of gratitude. That, all of us, regardless of what we're dealing with, and I don't mean to belittle anything that any of us are dealing with, for me, I got a job. For me, I was in medical school. For me, it was a struggle, but I got to live my dream. And you look at what's going on in the rest of the world, you realize that even with the struggles we have, even with what's going on, it can always be worse. And you may even just have gratitude for the people around you, for the one person that is, your go-to person for nurturing. So I'm going to finish with my two favorite quotes of medicine. One is from William Frederick Halsey Jr. Quote, "There are no great people in this world, only great challenges which ordinary people rise to meet," close quote. And that's, goes along with the quote attributed to Margaret Mead, that, the only way anything of consequences really change in this world is when a small group of people have banded together. So each of us, even though we may feel small and that things are overwhelming, that's how things change as we rise to the occasion. My other favorite quote is from Lewis Carroll, who wrote Alice in Wonderland. Quote, "One of the deep secrets of life is that all that is really worth doing is what we do for others," close quote, which I think defines why we go into the healthcare fields, or why, and it's not just healthcare. There are plenty. We have a law school here. We have a Health Justice Alliance, where we work with them around asylum clinics and advocating for improvement in healthcare lobbying at the national and level here in DC. It's business for good. It is education. It is a variety of things. So with that, I am going to stop sharing, and I will turn it back over to Sahara.
Perfect. Thank you so much, Dr. Jones. If you guys have any questions at all, please type them in the chat and we'll have Dr. Jones answer those for us. I do see that we have one question in the chat already. I am super interested in medical education or academic medicine. Is there anything you recommend or wish you had done in pre-med and medical school to prepare you for that sector?
That is an outstanding question. So I am one piece. People frequently say, "Oh, I want to be where you are. How did you get there?" And I look back and I think, boy, I did not have a plan. I just sort of was like, "Hey, this looks interesting. I'll do this for now," and then I did that. But thinking about it now that I'm in the position where I am, so for example, working at AAMC on the board and the other things I've done. In medical school, there's something called the Organization of Student Representatives. So every medical school has 2 to 4 representatives to the Association of American Medical Colleges. So while you're in medical school, you can become the OSR. rep, which means you get to go to all the national education meetings that AAMC sponsors. We have an annual meeting called Learn, Serve, Lead. The last one was just in Seattle. The next one's coming up in Atlanta. It's typically the first week in November. About 5,000 people come from all over the world, and there's a day and a half of programming just for the organization of student representatives from the medical schools. I did not do that. I did not know that existed in medical school. Many of my colleagues that I have the pleasure of serving with at AAMC did that. And I feel like, whoa, wait, you did that as a medical student and as a resident? I didn't realize I was interested in education until I was a chief resident, which is years after that. So I wish I had known about that moving forward. In retrospect, I should have recognized that I had an interest in education. I volunteered at the New York State School for the Deaf is in my hometown in Rome, New York. I volunteered to tutor and learn American Sign Language there, and I sort of ignored that. So I think there are definitely ways to get involved, and the best way is to get involved with teaching and tutoring and maintain that. Once you get to medical school, there's all sorts of opportunities to tutor. Once you're a second-year medical student, to tutor first-year students. If you're a first-year student that had an anatomy course as an undergrad, you can tutor first-year students that are in anatomy. And so I would advise you to take advantage of that, not to the point where it hurts your grades and what else you're doing, but it's a great way to get involved, to make connections, to network. And then as a resident, that's also true, and as a junior faculty member, it's true. There are a variety of ways. And I suspect there are clearly ways that you could be doing it as an undergrad or even in high school. Tutoring, getting involved with things like that are really, and it doesn't have to be education around, school. It could be teaching. I taught skiing growing up. It could be teaching swimming. It could be running the Sunday school class. Just sort of stretching and learning how to use those muscles that are used for that. So I hope that made sense and answered the question. Looks like there's a couple other questions. Did it answer it?
Yes, perfect.
Perfect.
Yeah, we do have a couple more questions. So the next one, I believe, is how did you choose between other healthcare professions, such as being a nurse or a PA?
Oh, you guys ask good questions. That's a difficult one. So I come from a family where my mother's brother and my great-grandfather were both physicians. They happened to both be surgeons. So that was the model I had growing up. And my best friend growing up, his father was the general surgeon in our hometown. And so I grew up with that as a model. I think you have to step back and think, what is the engagement you want to have with the people, with patients and your colleagues? So if you're someone that likes to be frontline, involved with the person, doing a lot of patient education, that's nursing. Now, that does not to say that with the nursing also covers a huge spectrum, that you can become a nurse clinical specialist in oncology and be right in there with the physicians managing the treatments. You can become a nurse practitioner where you see and evaluate and diagnose and treat patients, depending on the state, on your own or under supervision and collegiality with a physician. That takes a shorter amount of time. Medical school is 4 years of college, 4 years of medical school, 3 to 9 or 10 years for residency, depending on what you go into. PAs, it's a shorter program. However, PAs can do a variety of things, just like clinical nurse specialists and nurse practitioners. PAs assist in the operating room with things like neurosurgery. So it depends on what your level of engagement, what your level of autonomy you want to be, and how you want to work with colleagues and patients. For me, I like the autonomy of being a physician. I like being able to, as a psychiatrist, being able to do the therapy, being able to manage their medications. And for me, actually, to do consultation liaison was helpful. I do have to say, though, that in my previous jobs, the colleagues I worked most closely with were clinical nurse specialists that were outstanding consultation liaison for givers too. So again, it's the amount of education you want, the level, the length, and how you see yourself engaging with patients.
Perfect. And then another question, are there any programs for high schoolers that you recommend to get hands-on experience in the medical field?
Absolutely, there are. There are multiple programs, and I'll see if I can. I didn't think about that. I can get links that I can send to you. So, for example, here at Georgetown, we have pipeline programs that we have that are on Zoom. We have some that are residential programs, and they are ways to have a more in-depth experience, either with the specific physician or specific research, or rotating through a variety of things. So many of our medical schools and institutions have these kind of programs over the summer, or even longitudinally over the year, where they work with institutions. I actually am involved here in DC. Was involved with one of our high school pipeline programs where it was in residence. So I met with them 3 times over the summer they were here, and am continuing to maintain contact with them and speaking at their high schools now. And so there's a variety of programs like that. And let me see if I can find out. I believe there is a national database of that. So let me find that out and get that back to you to share with that. But there's definitely that. And the other thing you can do is typically hospitals will have the ability to volunteer in the emergency room or in the hospital. And from there, you can meet nurses, PAs, physicians, and start asking them questions. And you may, if you're persistent and lucky, and people are open to it, you can ask to shadow in person with people to get an idea of what. One of the things you can also do, if there's something called an informational interview, where you decide I'm going to ask 5 different kinds of physicians, what do they do? I've got 5 questions for each of them. Why did you choose this field? What's the thing you most like about this field? What's the most challenging part of this field? What do you miss about the other fields? And it's ways of getting information. So I promise I will look and see if I can. If I forget, remind me to see if I can find a national database for that.
Perfect. Yeah, you can send that over to me. And then for all of our people who are listening in, make sure you're following our Instagram and joining our email list. So we'll send that information to you guys through that. Okay, and then another question, would there be opportunities to participate in research without doing a MD or PhD program?
Absolutely. So as you saw, I did a year of research, 2 years of research. My first fellowship was research and clinical. My second fellowship was pure research. And so there's lots of opportunity to do a year or 2 of research. So classically, medical schools have a research or scholarly project requirement that can be met with research. So for example, here at Georgetown, we have that you have to complete your scholarly project by for graduation. But the summer between the first year of medical school and the second year of medical school, there's time open. Some people call it the last summer of your life. That's not, it sounds like it's not that extreme. It's just that the next year you're actually doing clinical rotations. But during that summer, you can do a variety of things. And we actually offer stipends for our medical students to get a taste of research over that summer. So roughly half the class will do research with that. And we have programs that help them get set up with areas of interest, a variety of things. And so you can do that for that summer, 7 weeks, 6 or 7 weeks, and get a taste of it. You can do research across the 4 years of medical school where you're working on projects in the background of what you're doing. You can take a year off and do a full year of research, typically between the first to third year, which is when you've done all the clinical rotations, in the 4th year. You can go on and get a master's and do that. And so there's a lot of opportunities to get research. And I want to make sure that when I say, that when I say research, you can do basic science bench research, but it could be community advocacy research. It could be, we have students, for example, here at Georgetown, looking at community health literacy research, looking at education research. So there's many opportunities in medical school to do, a 7-week project to a 4, 5, 6 year project without getting. And then, of course, there are MD, PhD programs. We happen to also have, just so you know, Many schools have MD, MBA programs, MD, MPH programs. The MPH programs tend to be 1 or 2 years, and you can do research during that. So there's a lot. One of my previous schools had an MD JD, so you could get an MD and a law degree. So there's lots of opportunities there.
Wow, that's amazing. Those are some cool opportunities. Um, Another question, do you have any recommendations for low GPA pre-med students?
Yes. So there's a couple of things to think about. So the application to medical school, as I went over, involves a lot of different things, and probably there's probably 2 or 3 things that are the most challenging for people. I'll get to the one that this one around GPA and ultimately MCAT scores. The other 2 are having not done enough scholarly work to show that you've got the bandwidth to do things, and not have done service or not have done a shadowing. So we're not sure of what you got to do. So, I have people that I have worked with in some of these programs that when we look at their application to medical school, why did they not get interviews, or why did they get interviews and not get in? We look at what's been going on, and for someone it might be they had no clinical experience. So we would recommend that they do scribing in the emergency room for a year or do shadowing. It may be that they didn't have service, so we recommend that they do service. GPA and is perhaps the largest, or the biggest one. And so there's a variety of things. I think it's very helpful to step back and look and see what was it that made the GPA low. If it's something along the lines of, as a freshman, I didn't have, coming into this as a freshman in college, I didn't have AP exams in high school. I struggled. And if you dropped my freshman year and looked at my junior and senior year, my grades are really great, but it's being brought down by the C's that I got their year. So there are medical schools that actually look at that progression. One of the things that we also look at is the MCAT to see, because that'll tell us, how you ultimately master the material. And then the other thing that we have are post-baccalaureate programs. And that may be the best way for people. And a certain percentage of each of our classes, pretty much at every medical school, are people that have done post-bac programs. Typically, they're a year. We have a post-bac program and a special master's program here at Georgetown that has a very high success rate of getting people into the health fields. And that may be the best way for you to show the medical school that your low GPA was indicative of being young, having not been prepared, a variety of things. But you can now show that you've mastered the ability, particularly in the sciences, to manage medical school. And just so you know, it's because the worst thing we can do is bring someone into medical school who isn't able to do it, and then they aren't able to finish medical school, but they have $180,000 debt from the first 3 years. So we really need to focus on that. I hope that answered the question.
Perfect, yes. And then another question, during your pre-med years, which course or courses would you say is best to try to memorize or have a strong foundation that will help during medical school? Are there any resources that you use when you are seeing patients and their concern is something that is not your strong suit, example, kidney functions?
Yeah, so here's the really good thing about medical school, is that once you're in, you'd have to actively try to avoid learning the things that are important to learn, because we do something called spiral learning, where you get it once and you get it again the next year and you get it again in the clinical year. And so you get a lot of exposure to that. I do think, which is why we have the prereqs that medical schools require, which are biology, chemistry, physics. Typically, we require a language or humanities. Genetics is another good thing, immunology, and you can look and see on the website what medical schools require. And those are the things that are most helpful to get you into medical school, and to let us know that you can manage that, but also so that once you're in medical school, we know you can handle it. But just to warn you, you will think, yes, I met the requirements, I did biochem, and you'll realize that when you're in the biochem course, they had covered what you did in a year in the first 3 weeks of the semester. So there's a lot going on, but that's why we have the prerequisites that we do, is so that you can do that. There are supplemental things that happen. There's all sorts of things that are available for students to help them learn in medical school and to continue learning. And so one of the things, the booklet that we all carry, except for infectious disease specialists, because they have it all memorized, is there's a booklet. It gets published every year. It's typically some bright color. It's a little booklet. Mine's in my white coat. That tells you what the antibiotics recommendations are for all sorts of things. And so the other thing that we recognize is that we all use our phones. I have two phones to look up things. There's something called Up to Date that we use incessantly to look up things to make sure we've got the most up-to-date information. So again, I think to answer that question is meet all the pre-med requirements, the admissions requirements for medical school. Make sure you have a foundation in biology, chemistry, and those things, and that'll serve you well.
Perfect. And then what is your advice for non-traditional medical school applicants that are career changers?
Yes. So as I said, here at Georgetown, and many schools are like this. While the average age is 24, we go up to age 38 first year for the first year medical students starting. So these are people that have done other things that are not coming straight from school. First of all, I need to say that people that have done that typically have much more life experience and they're able to keep things in perspective. My husband and I don't have kids. It never ceases to amaze me that people that come to medical school with kids tend to do really well in medical school because they have figured out how to balance kids and balance their life. I'm in awe of them. So, being non-traditional means that you probably you should pay attention to make sure you've got the grounding in what I just finished talking about a moment ago of the prerequisites, that you've got that under your belt. And that you also, because you've been away from the learning, I mean, people come straight from college, it's like you were used to exams and the pace. If you're a non-traditional student, is as you're applying to medical school, it depends on how non-traditional, you might have to do a post-bac, but it might be that you've met all the requirements 2 years ago, 3 years ago, and you've done something else and you're applying. It can often be helpful to, even at just a local community college, take a science course just to get your brain to start functioning around that. Take a chemistry course or take something like that to refamiliarize yourself with that. And then when you hit medical school, be very proactive and go to see that every medical school has a learning specialist, at least one, if not more, that can help you with what's the approaches you should take to learning. Because even if you come straight from college to medical school, but specifically if it's been a while since you've been studying, you can very easily get overwhelmed quickly with the volume. Nothing in medical school is particularly hard. It's the volume that you have to do. So if you're a non-traditional, make sure that you've met all the traditional requirements. Make sure that you get help around what's the best way that you can learn, as around adult learning with a learning specialist, and then seek help as things are moving forward for you.
Perfect. And then we have a question that I think you touched about a little bit earlier, but I'll ask it again just in case to reiterate any points. Would you recommend doing a dual degree program? I'm looking into a PAPMPH program, and a lot of the info you have provided is helpful, especially when it comes to the research and application of that knowledge in your work. Is there any feedback or knowledge you have of others who have done this?
So let me see if I make sure I understand the question. It's maybe it'd be helpful if I read it. It's in the. So the question is really around. Oh, here it is. Okay, I understand the question. So I think you need to step back and think about what is my ultimate goal here. Where is it that I want to be? So a master's of public health can be very helpful because you learn how to manage public health. You learn community programs and how to do things like that. It also could be just something that you're interested in, and that it may not be. There are people that have a clinical practice. For example, one of my colleagues, clinical practice in psychiatry, their research is in bird songs, how birds learn that looking at brain function. That is not related directly to things that they're doing clinically. So a PA MPH, you could either do that in that you want to have medical knowledge and do public health work, and that would be a very useful degree to have there doing that. And that's why people do dual degrees, because you learn skills there. However, if you're thinking I want to do more leadership kind of things, it may be a PA MBA is the way to go. If you're really going to focus on public policy, it may be a PA or MD or a nurse practitioner with an MPP, Master's in Public Policy, may be the way to go. So I think it's very helpful to step back and think, what is it that I'm trying to accomplish here? And check in by having discussions with people, because you probably didn't know that the MPPs existed. I didn't know that until I was getting my MD. So it's very helpful to talk with multiple people and mentors to help you determine where is it you want to go and what do you see yourself, and being able to adjust course. You may start out in PA school thinking you're going to add the MPH and realize, no, what I want to add is an MBA, or what I want to add is a GD, a JD or something like that.
Great. And then I think we have 3 more questions. What are the main elements that medical schools look for in personal statements?
That's a great question. So they're really looking for how can I get to know you as a person better? It's water. So it's looking at what is the motivation, who are you as a person, what is it you bring to medicine and perhaps to the school and our mission that will enhance, can you handle this? Why are you doing this? Our medical school class here is just over 200 at Georgetown, and we don't want 200 MD PhDs. We don't want 200 people that are all going to go out and do primary care, because the learning environment, people learn from each other. So when we look at personal statements, it's like, what does that tell us about you? How do we get to know you a bit? And in some ways, when we're trying to decide, does someone get an interview, we step back and someone goes down and looks at multiple applications to determine that. And the personal statement is a little bit like reading the back cover of a book or the inside cover of the book. It's like, what does this tell me about the book? What does this tell me about the person? And does it entice me to read more about that? So the things you want to cover in a personal statement is sort of why medicine for me, who am I, and what is it I'm looking forward to doing? Frequently, people begin it with a clinical story of what maybe illustrates why they're interested in medicine. So that's what we're looking for there. I can tell you that, sometimes you don't want to shoot for this has to be completely blown. You have to blow people out of the water, and you want it to be such a standout, because that can cross into being weird, and you don't want to cross into being weird. So you want to, and it's really, really, really important and helpful to have multiple people read your personal statement so that they can know, you get an idea. As well as, it's really important if you have access to an English teacher that can go over grammar and commas and things like that. You don't want to have those kinds of errors in your personal statement.
Perfect. And then have you seen any disadvantages for students who have completed some of their prereqs in a community college?
So that is variable across the country. There are schools, more so in the West, that look at community college, and like, for example, I think California, there's the community college, the Cal State, and the UC system, and that will take people from that. Other schools want it from a 4-year accredited school, and so there is a variability there. Many times what people will do is they will start off in a community college and transfer for the last 1 or 2 years, because the cost is of concern, obviously, to a full 4-year college, just to cover their bases with that. And I think the schools who are hesitant to accept people that have done all their prereqs at a community college. They're concerned about the rigor of that. So if there are ways that you can think about that can demonstrate the rigor and the understanding that the mastery you have, that would be very helpful.
Perfect. And then somebody asked, how did you know you wanted to go into pre-med?
Well, so my mother tells me I announced when I was in fourth grade that I was going to be a doctor. So I guess I went to college thinking, I don't remember that. Um, but I always knew that I wanted to, for a while it was vet. I thought about being a veterinarian, but then I love animals too much. It's like when I found out that you euthanize animals, it's like, yeah, I can't do that. So I just knew that for me, it was the intersection of science, because I really like sciences, and people, and I really like people. And so the intersection of that in conjunction with knowing medicine from colleagues, from friends' parents, and my uncle, it just was a logical choice to me to be able to do something that allowed me to learn a lot and develop mastery over an area of science, as well as be amongst people and connecting with people. So that for me, that was medicine. That's how I figured out that's what I wanted to do. And I for a while thought, could it be law? Could it be education? And I kept coming back to medicine as I sort of tried on other things, and it just made the most sense for me.
Perfect. And then last question so far that we have is a bit niche, but I have an MMI interview in a couple of days. Do you have any tips on the mindset to approach it in?
Yes, congratulations first on interviews. So for those of people that don't know, MMI has multiple miniature interviews. So the way medical schools do interviews, when you're fortunate enough to have gotten an interview, again, congratulations, one can either have traditional, where you meet with one or two people, typically a faculty member and maybe a student or a community member, and they have a standardized set of questions that they ask, and you just have a one-on-one interaction. There are sometimes group interviews where it's a mixture of those things, but the MMI is where there are stations. Classically, there are 10. It was pioneered by a school called McAllister in Canada. It's a standardized way of doing it. And so what it is there's 10 stations. You have 10 minutes at each station. And when you get to a station, there's a prompt that tells you the background. It's typically 3 lines about what's going on in there. And then you go in the room, and there is a standardized patient that's been trained that you interact with, and you have to follow the scenario to get information or have a discussion with them. And what we're looking at the MMI is not did you get everything right, not did you ask all the questions. It's looking for relationship and how you manage anxiety and what your discussion is like. So I think my best advice is at each of the doors before you go in, take a deep breath and recognize it's 3 lines. I'm going to be in there for 10 minutes. And what I like to think about is if this was a scenario with a family member or a friend, how would I do it? So what are the mistakes people make? Don't get angry. Because the person there may have that their whole task may be to be oppositional with you. So, and stay focused on what the task was in the 3 to 5 sentences before you went in there. And don't get caught up, and I have to do it perfectly. Because most of these don't have a perfect answer. There is no right way. And if you actually took, and several places have done that, if you took practicing physicians in and took 10 physicians in to do the same scenario, you get 10 different ways of doing it. So don't feel like you have to fit into a mold and do it, but do focus on what the task is and address it and try to get it. And you don't have to complete it. Whatever the task may be, it may take 6 steps. You maybe only get to the first 2, but we're looking at, how do you do that? How do you handle it? How do you react? And then we move on to the next one. And so you have to be able to like focus, drop, walk to the next one, focus, drop, walk to the next one. So that's the other advice I have is let go of the one you just came from and focus on the new one. It's a bit like being an emergency room physician. When I'm in the emergency department, it's like I have to focus on what this person is doing, which could be emotional, it could be terrible. But then when I come out, I have to take a deep breath and go into the next person. And let me tell you, it can be jarring. You go from someone who is very depressed and has suicidal thoughts to someone who is bipolar and is manic and is making you laugh. You get sort of whiplash. But an MMI will not be that extreme. But that's what it's about.
Looks like we had 2 more questions come in. Can you speak on a memory from your psychiatric work that sticks out to you?
Oh, yes. So I remember during my fellowship at Memorial Sloan Kettering, there were several protocols I was on that had a very high mortality rate. We were looking for ways of new treatments for people who had multiple treatments and their cancer continued to progress. And I remember a woman who had been in with several bone marrow transplants, where you basically take out their entire immune system because that's where the cancer is, really treat them very potently, and then put back in either their own immune system that's been treated or someone else who's compatible with immune system. And we had a woman that I had gotten to know quite well over the year because she had had two bone marrow transplants. It became evident that I may get a little tearful here. It became evident that there was nothing we could do any further, and so we were doing comfort only. And I walked in after a night on call. I spent at least an hour every day in her room. I got to know her husband very well. They've been married for over 60 years. And I walked in and they were burning candles. The room smelled, well, not real candles, the light candles. The room smelled great. And she motioned for me to sit down on her bed. And then her husband came up behind me and put his hand on my shoulder. And he said, "We're worried about you. You look tired. Are you getting enough sleep? Are you eating?" And I thought, "You're worried about me? You're worried about me?" And I just started crying on the spot. It's like, and then I felt like an idiot because it's like, I'm not supposed to be the one that's crying. And which they said is that's what makes you a great doctor, is you're here with us through this. And so for me, that stands out because I realized what I knew all along, but it brought to the forefront how important relationships were and how important connecting was. And that at the end of all of this, doctor or patient, it's two human beings in a room trying to do the best that they can to get people better and to make life the best it can possibly be, given whatever the circumstance is. So you're not supposed to make a psychiatrist cry, but you managed to do that.
It's amazing to know that we have doctors who are so passionate about their work. So I'm jumping to a more studious question. How would you recommend studying for the MCAT?
So there are a variety of resources available. Again, because I'm on the board of directors at AAMC, we have actually tools to help with that. And the really wonderful thing is we have a fee assistance program that we just expanded, so that you have access to reduced costs for the MCAT, as well as all of the resources that we make available. So I recommend going to AAMC.org, and you can, on the search there, look up MCAT assistance or fee assistance, and they will tell you exactly everything that's available for you. The really wonderful thing is that fee assistance program will continue for you when it comes time for you to apply for residency, because it goes with the MCAT, it goes with the actual cost of the MCAT, the resources available to study guides, what you should be doing. It also, there's a fee assistance program for the application process on AMCAS. And then we just announced that this is going to continue for the people that got fee assistance and access to all those resources when you apply for residency, which is another costly time. we will be using the fee assistance program. So I feel a little bit like I'm hawking my web page, but it's free, so you can go do it. I get nothing out of it, and that you all are the reasons it's there, not just for fee assistance if you need that. If you don't, there's multiple resources there about how best to study for the MCAT.
Perfect.
And
Well, go
I was
ahead.
going to say, note to self, we actually own the MCAT. The MCAT, AAMC does it. So if anyone knows how to study for the MCAT, I think it's AAMC.
Perfect. Well, I think that's all the questions. So thank you so much for all of your time and knowledge and wisdom, Dr. Jones. I'll go
Yes,
ahead and
thank you
share
so
the
much. It was,
presentation.
sorry, I was going to say thank you so much. It's so inspirational and informative. Thank you for your time.
So my one last piece of advice is stick with your dream, whatever it may be. It may modify, but hold on to a dream. Don't let anyone tell you you can't do it. I'm sure you've already had people, based on who you are, whatever that may be, tell you you can't do it. I had that. I use that to motivate me even more. And so stick with the dream, get help, and I wish you all the luck and Godspeed to getting to where you want to be. And let me tell you, whatever area of healthcare it can be, as well as other things, it's so worth it. I wake up every morning rearing to go, and I close my eyes at night knowing it may have been a stressful day, but I feel like I made a difference in someone's life. And that's the reward of being a physician or a healthcare doer. So good luck, stick with your dreams. It's been a pleasure.
Thank you, Dr. Jones. I'll go ahead and share that presentation real quick with you guys.
I am going to go feed 3 very hungry dogs. So I'll step off right now. Take care.
Bye, Dr. Jones. Thank you. Okay, thank you guys all for coming and joining our session today. Let's reflect. What brought you to the session today? What are 3 major takeaways you got from the presentation, and what do you want to learn more about? And if you'd like some recognition, make sure that you submit your articles, reflections, reviews, and success stories on our blog on our website so that you can get featured. And again, if you're interested in being a part of our student volunteer team or our team member team or becoming a leader, please visit our website for more information on that. And if you can, please donate to help our program stay free and accessible to everyone. We do run solely off of the time and donation of our volunteers. And make sure that you do complete that digital certificate on our website. It is a simple 10-question multiple choice quiz, and you have 2 chances to pass in the 70% or higher for verification of your virtual shadowing hours. That quiz is up and running right now, so go ahead and take that. And if you missed any part of the session, we will be posting it on our YouTube channel, and be sure to catch our sessions every week. And we'll see you next time at Free Health Shadowing. Thank you guys so much. Bye-bye.